solutions. I have largely assisted with patient complaints in my current role advising providers and administrators in their practice. So we can get started. So this is my disclosure and disclaimer for this presentation. Give this a moment for y'all to look at. And here are the objectives for this presentation. So by the end, you should be able to list 3 ways to encourage patients to communicate a complaint, describe 4 ways to respond to a complaint, demonstrate how to document a complaint in the medical record, and lastly, understand the relevant state laws understand the relevant state laws on providing patients refunds or reimbursements for care. So let's begin. What defines a complaint from a patient? So generally, any expression of dissatisfaction regarding the care experience, specifically related to quality, treatment, or the actual service that was received is considered a complaint. Now, the word complaint has a bad rap in healthcare and is seemingly seen as a negative, right? But complaints can actually be considered positive because they provide valuable feedback that can be used to identify areas for improvement in healthcare delivery, leading to better patient outcomes and overall quality of care. So despite the positive spin I put on this, we ultimately want to hear the good, right? As it relates to the patient experience and satisfaction with the care and treatment that are rendered. Thus, there are some pillars that can help to eliminate or mitigate some patient complaints, and they include solid communication, which is active listening, empathy, sincerity, service recovery, which is commitment, rebuilding trust and integrity, and lastly, training, right? So identifying the right people with the right skill set, investing in that training, and creating a culture of safety. So for malpractice claims, the top contributing factors are clinical judgment, technical skills, and no surprise, communication. Approximately 30% of all malpractice claims have some component of miscommunication. So there's been some poor communication between providers and the patient or families, or poor communication between providers and colleagues and staff members. So it's important to invest in developing skillful communication practices and interacting with patients and their colleagues. So that solid communication must start from the beginning. It just has to establish trust and respect for the patient and obviously the environment as well at the practice. So the tone of the visit is set once the patient checks in from the front desk, and this carries through the entire encounter. Some studies have shown when there is a good communication between the patient and the practice, even when things go wrong, the patient is less likely to complain and even sue. So how do we get to know what your patients are experiencing and feeling when they come to your practice for a visit, or when they call in with a question about their care, or they leave, a comment or a question in the portal? Encouraging patients to complain might seem a little counterintuitive, but as a practice manager or provider, would you rather hear directly from your patients about concerns and complaints related to you, or would you prefer to see them posted on the internet, or escalated around the practice, or to the medical board, or to the Office of Health and Human Services? You want to hear directly from patients. So it's advisable to consider managing patient complaints proactively, encouraging patients to complain. This can be accomplished by developing ways to do that, and for providing avenues for patients to communicate directly with you. So there are a few ways to formalize hearing from patients directly. The first is to establish, a formal complaint policy. This can help ensure that appropriate action is taken on all patient complaints. Frequently, the clues that a patient may sue are present long before any legal documents are actually drawn up. All complaints deserve a prompt professional response. So the policy should include how the practice will respond to, track, and implement necessary changes and processes that are necessary. The care team members should be encouraged to document and report all patient complaints and feedback. And two, there needs to be a standardized complaint form as an effective tool for easy and accurate reporting to the administrator and the patient's clinician if one is involved. So it's important to recommend that all follow-up to the complaint be documented on the form to capture the closure of the issue. Track the number and type of complaints that are received. This will help to ensure that recurring complaints are identified and addressed on an organization-wide basis. And then after you have your policy in your form, you want to develop a document that actually informs patients how to contact the practice when they have a complaint and that your practice has a policy. So you need to include this information in each new patient packet and distribute annually to current patients. And then lastly, we have the beloved patient satisfaction surveys. So you want to administer your patient satisfaction survey periodically. This will enable your practice to be proactive about correcting any system problems that may exist and improve the patient experience. Surveys can be useful for obtaining feedback from patients about their experience. These surveys allow the patient to identify areas of dissatisfaction and aid the organization in monitoring potential risk management concerns. And really, to be effective, these survey results need to be shared with providers and staff, and the appropriate changes need to be made to respond to those patient complaints or concerns. So we've established how to set up procedures to facilitate receiving feedback or complaints from patients. Now let's transition to how you may respond. And there are 4 ways to do that, at least that I'm recommending. First being service recovery, HERD protocol, which I'll talk in detail about, and online reputation management. And lastly is patient termination. So when we think about customer service in the medical practice, we often think of the basic things we need to do for patients, right? We need to be respectful and courteous. We try to schedule appointments at convenient times. We try to minimize wait times and answer billing questions. But really, what happens when you come face to face with patient dissatisfaction? What do you do when you have an outreach patient that's complaining in the waiting room? How do you intervene? You can manage these types of patient complaints by using a service recovery model. So service recovery is sometimes, interchanged with customer service, but they're very different. So service recovery is more than simply providing, the customer service, which is mostly concerned with meeting patient expectations. Service recovery, in contrast, includes good customer service, but has an investment in the patient experience that is reflected in the practice's mission and formal processes to recover dissatisfied or lost members or patients. So it yields patient loyalty because of effective resolution to patient complaints. So as mentioned, service recovery is an integral part of an organization's culture. So Some considerations that you may have in implementing a service recovery program in your practice. One is from AHRQ to establish processes to make things right after something has gone wrong in the healthcare experience. They have a 6-step intervention process, which includes apologizing or acknowledging. This is essentially just acknowledging the patient's concern, right? Secondly, is listening and empathizing and asking open-ended questions, just understanding from the patient's perspective, what has occurred and what has gone wrong. Third is fixing the problem quickly and fairly. So this really just means providing a timely response to their concern once you have all the facts. Obviously, you want to give deference to the patient and their experience, but you also want to know all the factual things that took place and from other parties as well, if that is included. So if you have the time to do that kind of investigation and then respond with all the facts in a prompt way, that's the way to go about that. Fourth is offer atonement. So this is really just reparations or compensation for dissatisfaction. For example, if you are you have patients that have been waiting for a specific time in the doctor's office that has gone way past their visit. You may offer some sort of parking, voucher to that patient or patients to, recognize that they've been waiting. And obviously, while they've been waiting, kind of racking up the fees of having been parked, you can offer them the voucher perhaps as well. Just to recognize, again, their experience. The fifth is follow-up. I mean, that's pretty self-explanatory. If there is any type of complaint, you want to just make sure after you've responded, again, to follow up about the care that they've received and that you have, satisfied their expectations for alleviating or responding to that complaint. And then 6 is just remember your promises. So just do what you say you will or would do in the future as it relates to responding in a timely manner or providing some sort of reimbursement or compensation. And lastly, training. Training and education must include a review of the practices, policy and procedure, how patient complaints affect the practice as well as each person's job, each staff member's responsibility in responding to patient complaints, and appropriate documentation of patient complaints in the medical record. So similarly, the Center for Patient and Professional Advocacy, that's CPPA at Vanderbilt University Medical Center, they developed the HERD protocol as a method to respond to patient complaints. So it's essentially requiring just some of the same things as the AHRQ in terms of listening, communication, and problem solving. CPPA is nationally recognized for studying the relationship between patient complaint data and medical malpractice claims. So what is the HERD protocol? It's an acronym for the response process. The first H is hear the patient. So again, if you're faced with a patient in person, some of this may apply as well, over the phone in your interactions with the patient. Obviously, if you're new to the patient, introduce yourself, focus on that individual, ask open-ended questions with regards to their experience, and just be very slow to interrupt when they are, expressing themselves about their dissatisfaction or concern. The E is empathize, identify with the patient or the family. I think there's a way to do this in a way that is obviously establishing connection, but not necessarily taking away from their their own experience. So if you're able to identify with that patient or family member, you should be able to do so. And I think that will establish some trust as well. Understand the patient's feelings, respond to the family um, or patient or family using the appropriate phrases. Always words are important, right? So it's important to just be conscious about the language that you're using and just always be sincere. Third is acknowledge. The A is acknowledge there. So acknowledge the patient's concerns, again, giving them their space to explain what happened and from their point of view. You may apologize for the situation. I will talk more about apologizing later, but in this situation, just apologizing for the situation broadly is okay. Avoid being defensive. You know, I think it's important to just again recognize the patient's position, not necessarily say that anything's blameworthy on them, and then always remain positive and thank them for sharing that concern with you. Fourth is respond to the problem. Tell the patient or family member what you will do. Provide a time frame, again, for follow-up. Always follow through with the time frame that you set. If it changes, communicate that has changed. You're still going to be working on it and trying to respond in a appropriate way that will satisfy their response to their concern. And then lastly is document, just make sure to document all interactions with the patient. Now, things are a bit different when you are not faced with the concerned patient in person, right? But rather it's online. So we know that these days a strong online presence is essential to maintaining a thriving business, and responding to online reviews is a key element of that presence. So that's all called online reputation management. So understanding how to appropriately respond within the parameters of privacy laws can be nuanced, and it's recommended that practices actually engage the help of experts to manage their online presence to avoid any liability. Unless you have an expert, obviously that's in your office. We usually advise to hire a company or a vendor to do so on your behalf. At the very least, practices should appoint a designated individual to respond to all online reviews using only templates for responses. And so these are just some common internet sites for physician review and practice review. Obviously, Google is a huge one that people use. So by the numbers, 90% of people use online reviews to evaluate physicians. So that's huge. I mean, the online world and your reputation is out there as a practice and for providers, and that's what people are looking at. So you obviously want that to be a positive one um, that exists. And 7 out of 10 patients use online reviews as the first step to finding a new physician. Again, everything is online these days, and that's so it's important to have that online reputation management. So then the question is, how should you respond to a bad review or a complaint online, right? So regardless of motivation, physicians and practices, they cannot disclose patient information to defend themselves without valid HIPAA authorization, even if the patient has publicly discussed the same information. So it's advisable that medical practices must conform that that their responses to public patient complaints comply with all HIPAA requirements. As a rule, these issues should be handled privately, and providers should not engage in any public debate on these issues. So these are a few of my top how-tos for online reputation management. So if you discover that a patient has posted something negative about yourself or your practice, the question is, what should you do? Again, appoint a designated individual to respond to online reviews. Respond as soon as you can, as soon as possible, to prevent any continual reviews or comments on your reviews from others from taking place. So try to be apprised of what's on your profiles out there. Investigate any negative feedback. Follow up on negative reviews. If they trigger a prompt and direct phone call, but never back and forth online review on the online review platform. So obviously, if you are able to identify this patient from the information that they've posted online, it's okay to actually call them and, begin a conversation about their experience. But this should never take place online. And then you want to contact external experts before posting any response deviating from the language used in the appropriate templates. So I'm going to show you what those templates are next. So here are a few templated responses. So give only generic responses that do not relate to the specific patient or complaint. Providers should neither confirm nor deny that a patient has been seen or treated at the practice. There should be no statement addressing the concern raised by the patient. In most cases, a response of no comment or we do not comment on the patient issues is sufficient. In some cases, such as in response to an injury, the Better Business Bureau has a slightly longer response that might be necessary, but where there's a failure to respond, it may be held against the practice. So again, you have to be conscious about what you are saying and responding to on in these patient complaints. So an example of an effective and HIPAA compliant response under the circumstances could be, as seen here, thank you for the information regarding name given. We take pride in delivering excellent care to our patients. If a patient is unhappy with the care or treatment they have received, we welcome the opportunity to discuss these concerns directly with the patient. Boom, done. It's templated, but it allows you, again, to show that you guys are actually, present online, looking at these reviews, reviewing them and responding to them appropriately online. But behind the scenes, you can be doing your own investigation to find out who these patients are and contacting them. So when contacting the patients directly, the identity of the patient making the complaint about the practice, if it's disclosed, again, attempt to contact him or her. If the patient can be reached, the practice representative should focus on listening, being empathetic, and trying to resolve the concern. And again, practices should document all communications with patients, including the issues discussed and any resolution that was reached. Okay, so you can attempt to prevent the posting of negative reviews or education. This is something that may be possible to do. I guess, one way to go about doing this would be to, work with your vendor, see what the options are in doing that. But all in all, you should try to provide multiple avenues for patients to express concerns directly with your practice. Use your established patient satisfaction survey or complaint process. These are all things to really mitigate that online bad review, right? If you're doing these things proactively upfront, it's less likely that patients will go online and start complaining that way if they know that they have a relationship or a way to communicate with the practice directly through these other means. So then we talked about what you may do in response to a patient complaint. Now, what are the don'ts? They include the following. And some of these might be, again, self-explanatory, but it's amazing what we've seen, and what I've seen out there online from practices. But these are just some takeaways to remember not to do. They include being defensive. Don't let your emotions play a part in responses. The public domain is just not a place to unload, feelings about the situation or recount your own experience. Respond to specifics. In that, do not mention the practice or the patient's name. Do not even remotely infer or confirm that the review relates to a patient of the practice. Do not mention details that could identify the patient, and do not acknowledge that the practice was involved in the treatment that is the subject of the review. And some people have, hired a vendor that would allow for positive reviews to pay for that. We don't advise that as well. It's nice to have things be organic. Sometimes, especially these days with some of these responses and bots, people can tell whether or not they are real or not, if they're actually, patients or people that have made these comments versus, being paid for and their canned reviews to make the practice look good. So it's just not advisable to just pay for those reviews. And lastly, we will be talking about patient termination, and that is really just the last resort as it comes to responding to a complaint from a patient. Sometimes it's appropriate, as I'll detail here, but I left this last because it should never be the first thing in responding to a complaint. So examples of when terminating a patient may be appropriate are if it is your opinion that the patient's dissatisfaction with the medical office and the physician has irreparably been impaired or impaired the physician-patient relationship. Um, Non-compliance, that's another one. Obviously with a number of these that I'll mention here, the five that are here, you obviously want to be doing your due diligence before you make the decision to terminate based on any of these four, and just learn from the patient what any circumstances there may be before you just go to termination. Abusive language and behavior, that's another one. Repeated no-shows, it's important to know why that may be happening. There might be some social factors, obviously transportation access, things of that nature that might be hindering the patient in and showing up for their appointments. So just knowing about that versus, if they are just not showing up for no reason at all. Failure to make payments on financial obligations. That's obviously something that might snowball, and just, there might be opportunity to work with that patient, putting them on a patient plan or a payment plan to satisfy those obligations. If again, there are circumstances that are showing that might be a need. So before dismissal, can just consider some of these questions. Again, as I mentioned, there might be social determinants of health contributing to the non-compliance. Those things, has there been a failure in communication? Is there other health equity issues between the patient and the care team that, have not come out as being transparent? See if those things exist and see how the providers can work with that patient. Are there issues? Are there other issues that have been clearly communicated to the patient or responsibility party or a family member? Just make sure that, again, clear communication amongst everybody. And then, has service recovery completely failed? Have you exhausted all of the the options in terms of getting some sort of agreeable a resolution. So when it comes to termination, golden rule is really, when to proceed with it and when to delay, knowing when to delay termination and when just not to terminate and avoid patient abandonment altogether. And as we know, patient abandonment is a real issue, excuse me, and can be the basis of a lawsuit. So it's just essential to follow your policies. For example, the physician is responsible for making the decision to terminate, right? Nobody else should be making that decision. Obviously, as a practice manager or administrator, there might be some administrative or other things that are going on with this patient, but ultimately, it is up to the physician to terminate their care for this patient. So that has to come from them. Do not terminate in the middle of active treatment or with outstanding diagnostic tests. This has come up, I've seen a few times. It's just a big no-no not to do. You want to be able to provide a 30-day supply of maintenance medications. Obviously, if it's narcotics, that might be a minimal supply, if any, that's given. You want to offer a 30-day transition period in the form of emergency care. Some exceptions do apply here. Provide resources for locating alternative care if a patient is going to, seek care at another facility or doesn't, have the resources to know, where what physicians are there that are located or what practices there. You can provide that information to them. And you want to facilitate transition of care with copies of medical records to new providers at the patient's request, of course. And this would all be in a termination letter to the patient. So there are times, even though it's the last resort, there are times when their termination needs to be effective immediately. Most of the time, these instances are when there's some experience of threats of violence from patients or family members, if their patients are abusive, or the relationship is terminated immediately by the patient. So in those instances, there should be, no tolerance for violent threats against a provider. That's number one, staff or other patients while in the practice. So immediate action must be taken to ensure the safety of providers, staff, and other patients. So if there's any threats of that nature, that needs to happen, that termination needs to happen immediately. So we talked about how to respond. Let's talk about how we document our responses and really our interactions with the patient. So documenting patient complaints is an essential component in your complaint management program. The documentation can be used as a tracking system to detect patterns of service failures. So what information is actually appropriate to document in the medical record, right? Care or treatment related problems that were discussed with the patient, those may be documented in the record. They may include acknowledgement of an issue, what the patient was told, the patient or the patient's family's reaction and response objectively stated of that outcome or resolution. And it's important, again, I use the word objective because you want to make sure, again, that you're just sticking to the facts of things and not imputing any type of feelings, bias, any of those things that might exist in the situation. So just state things objectively. In addition, any correspondences with the patient should be documented in the record. For example, phone calls, emails, etc. However, the details about the conversation should be limited to some degree. Again, this record goes with the patient forever and it exists. If there's a malpractice suit that comes up, this will be pulled, and thoughts, feelings, all of those things that might be connected to the practice or providers would be evidence. So it's important to just be conscious of that and how the record keeping is kept. Oops. Did I go too far? No, I didn't. Okay. So in contrast, the following should not be included in the medical record. Patient complaint forms, that should never be in the medical record. This should be kept, that should be kept separately, along with, again, incident reports, things of that nature. I remember anything placed in the patient's medical record will become a part of the official record. So the complaint form should be maintained in a separate file with access being limited to the practice manager or administrator. It's advisable that the patient complaint process be incorporated into the practice's quality improvement program. Again, you don't want to have any statements about speculation or blame, feelings or thoughts. You don't want to be detailing the research and investigation process, after you've received a complaint, any correspondence having to do with a potential claim against the physician or practice, that stuff should not be in there. And then again, post-investigation, if you do a peer review in your practice, that should not be in there either. All this stuff should be separate. So in the same vein of how to respond and document, it's imperative to acknowledge the laws that are contextual features in the patient complaint situations. So in Delaware, you have an apology law. So this statute, 4318, it talks about compassionate communication. So it states, and this is B, so I've extracted it from the complete statute. It says any and all statements, writings, gestures, or affirmations made by a healthcare provider or any employee of a healthcare provider that express apology. And then I just went down here, another highlighted, with the exception of the admission of liability or fault, they are admissible in a civil action that is brought against a healthcare provider. So what does this mean? So to summarize the statute, of this apology law, it essentially encourages certain types of apologies to patients and families, right? Again, apologizing for the incident happening, things of that nature, your experience, those are all okay to do. And Delaware prevents such statements from being used as evidence against a provider or physician. Such protections, though, do not extend to an admission of fault or legal responsibility for the bad outcome. So if you say, I'm sorry for, X, Y, and Z that I did, in performing your procedure, for the injury that I caused you, those statements will be admissible. Statements of regret for a patient's circumstances, for example, again, I'm sorry for your experience, those are appropriate in the right set of circumstances. So those might be okay to say. However, statements of admission of error or wrongdoing, I'm sorry for what I did, again, or I made a mistake and I'm sorry for that, that should always be avoided. Now, also necessity to know are the payment laws. And Delaware's payment law, this is statute 4317, admission of accommodation payments for personal injury. So what I've highlighted here is the relevant part for you all. No advance payment or partial payment of damages made by any person or his or her insurer as an accommodation to an injured person or on such person's behalf shall be construed as admission of liability by the person claimed against or the insurer's recognition of such liability. So what does that mean? So again, to summarize the statute, the payment law essentially prevents payments that are provided from being used as evidence for proving liability of injury. So, with the law, I always say it depends. But essentially, it's saying that if you provide a payment, perhaps, some sort of compensation or reimbursement to a patient, um, with regards to a complaint or concern, that would not be admissible for proving liability for that injury that the patient might be mentioning in their complaint. Um, Payments provided to a patient may constitute a credit and be deductible from any settlement made or judgment rendered. So, say thereafter you provide this payment and the patient moves forward to have file a suit against you, there's a potential that this might be the payment that you provided earlier might constitute a credit and might be deducted from any judgment if that judgment is in favor of the patient. Um, and lastly, any provider, practice, or insurer who makes a payment must, at the time of the payment, notify the recipient in writing of the recipient in writing of the statute of limitations applicable to the patient's injury or death. So you just have to let that patient know that there is a statute of limitations that runs along with their claim of injury. So, what does this all mean with regards to practice receiving a request or provider receiving a request from a patient for refund of care or demand for reimbursement? So, this is ultimately a business decision. Um, it's really it's at the discretion of the practice. It's advisable to contact your billing professional and malpractice carrier to really just provide notice of a patient request or demand for refund or reimbursement. For example, a billing professional will know that they have to report um, issuing a refund to a patient for services that was rendered, under Medicare or Medicaid, right? And that there are prohibitions in refunding co-payments, and many actual private insurers take the position that if the patient's copay or deductibles waived or refunded, the insurer does not have any obligation to pay the clinician or the remaining fee for the services rendered. So, especially with Medicare, you can get into some big trouble. So it's good to always pass along any of these requests or demands to your billing professional malpractice carrier before you act and give money, because that can put you really in an issue. Um, and lastly, a malpractice carrier will know the relevant laws and advise you on mandatory reporting when considering paying a refund to a patient. And depending on the details, they will likely be able to manage the situation on your behalf. So just keep that in mind as well. So as I wrap up, patient concerns or complaints made to the practice should never go unresolved. Again, as I put my positive spin on earlier with the receiving a patient complaint, it just provides a valuable source of information to identify communication and process breakdowns. Um, when you have unresolved complaints, they can just contribute to the malpractice lawsuit. And if there is a medical board complaint, so just always respond to those and find a way to do so that's appropriate. Um, and lastly, missed opportunities to fix problems before they usually escalate to being out of control again in some sort of lawsuit or medical board complaint. So some final tips for you to consider as you review your patient complaint management are, look when you're looking at your own process, who does all this in your office? Is there anyone specific, or is it a number of people? or is it just left to whoever receives the complaint, you know? And you have to think about, are those individuals properly trained? We talked about service recovery. Um, we also talked about the herd protocol. You know, you want to make sure that the people that are interfacing with patients with regard to these complaints are trained to do so. And just change your thoughts about patient complaints, look for the value and make positive changes, track again all your patient complaints, categorize and study the data, find trends, see where you can get ahead of things and try to mitigate any potential issues. Um, think before you terminate. Again, it's usually the last resort. There are instances again, as I mentioned, that really necessitate that happening immediately, but it should be a last resort. And welcome a culture of safety for the care team and patients to express concerns and document. It's just important to just always have a record of what of 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 the patient's concern when they notify you, what was actually done to respond, and have that stored in a appropriate place. And then lastly, just take time to visit your support systems, your electronic healthcare records. Some of them have, you know, tracking systems or abilities that will enable you to find trends, and just be apprised of what might be driving some of the complaints. Here are my references. And thank you for attending today. I sincerely hope that the information shared will benefit you, your care teams, and your practice.
Thank you. Thank you so much for that great presentation. We did have a question that came in through our chat here.
Mhm.
And the question is, are the refunds that you talk about only if the patient is complaining or if they have a credit? Because if they were charged a visit, they did not need to pay. We have a we have had a lot of people who drop certain plans and do not have copays anymore, and we have been reimbursing them. Is that wrong?
Oh, let me actually. That's a longer one. Let me see if I
I
can
know you
read.
might want to read it.
Let me read it. Let me see if I can. Okay, I can see here. So, and I'm trying to just understand the question a little bit more. Is there a way to unmute, perhaps?
Yes,
Okay.
if
If this person can, if I can talk to this person. Oh,
Hello.
I have some questions. Hi, Helen. How are you?
Good. How are you?
Fine, thanks.
So we've noticed like some patients, especially this year, they either changed plans or they dropped their Advantage plan or they dropped some insurance they had and they're going straight Medicaid or straight Medicare, but they've had a balance um, in their account for whatever reason. Either they were charged for an annual wellness visit, which they
Mhm.
should not have been. So we've been just giving the credits back to like writing checks to the patients and just putting at the bottom reimbursement. Is that wrong?
Oh, that's interesting. That's a hard one. I don't want to say that it is, because I think that I would actually advise to maybe call. You said they were Medicare patients.
So they were Medicare Advantage patients, or they had Medicare and another insurance, and they had a copay with the other insurance.
Okay, I see. But they no longer have that copay,
Correct.
and you guys
Yes. Or
have.
they went straight Medicaid and we can't, charge them for anything. But they've had a credit in the past for whatever reason, say they had an insurance and then we charged them for an annual wellness visit, which is free.
Mhm.
So we just left it. We're like, oh, when you come back, next time we see you. Well, then next time we'd see them, they wouldn't have to pay for anything because they
They
went
have that
straight
credit.
Medicaid. Yeah.
Okay. Yeah, I think that the credit should be fine. I'm honestly not quite sure. This is the first time I've heard this situation. but I could follow up with you offline if you don't mind, so I can learn more about this. But I haven't heard of this situation before.
Yeah, sure, that would be great.
Okay. If you can, if you don't feel, if you feel okay, if you feel comfortable leaving your information in the chat, just an email, I can follow up with you that way or phone number.
Okay, great.
Okay.
Um, are there any additional questions that anybody want to pop in and ask any questions?
Okay.
Hi, it's Lynn Robinson. I do have a question. Kayla, great presentation. Thank you so much. Um, one thing I'll comment on Helen is I do teach this in class as well, and I always advise not to keep patient refunds on your books. So, after 128 days, or 120 days, you don't want to have patient balance refunds sitting on your book. So, just from an accounting standpoint. I know you talked about terminating the physician-patient terminating that relationship.
Yeah.
And forgive me if I missed it. You talked about the interim support, that you recommend providing to patients, but did you talk about how you physically, if you're terminating that relationship, how you get that notice to the patient?
Yeah, so I would again, and I did, and I apologize for that. It's usually the patient termination letter. Is that what you're talking about, the communication?
And how do you recommend that the physician send that letter?
Sure. So you want to send the letter certified mail, 2 copies, one certified, and then keep receipts of obviously when it's been delivered, and just upload that into medical record to show that you guys did your due diligence and actually notifying that patient of the termination. So again, it's just the letter, and then certified copy, one regular mail, one certified copy, keep the receipt.
Thank you so much. Right, because you want to show that you've made every effort to notify that patient, and you've made a good faith effort. They're still terminated once the notices have gone out,
That's
correct?
correct. That's
Mhm.
correct.
Okay, thank you.
You're very welcome.
Thank you. Does anybody else have any other questions? Okay, great. I want to thank you again for a great presentation. This session has been recorded, and if you're interested in reviewing this, we will be posting this on our homepage at medicalsocietyofdelaware.org. Feel free to visit. Thank you again for a great presentation. Everybody have a great day.
Thank you. Feel free to contact me with any other questions. Have a good
Thank
one.
you so much. You too.
Bye-bye.